Hello, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. We're going to talk today to a doctor who's going to talk to us on behavioral strategies, something we all deal with, people who are impacted with dementia. Dr. Andrew Budson is Chief of Cognitive and Behavioral Neurology at the Veterans Affairs Boston Healthcare System. He's also the co-author of an upcoming book, soon to hit the press, called 6 Steps to Managing Alzheimer's Disease and Dementia. Dr. Budson, thank you so much for joining us.
Oh, it's my pleasure. Thanks for having me.
Now, the reason why I was so excited to talk to you is because the opportunity to really talk to a doctor about behavioral strategies. I mean, I know with my family, we go through this. You know, I was telling you, we just had an appointment with my mom's doctor, and we want to talk about how we help change behaviors or assist with behaviors. And that's really top of the list. So I love it when a doctor has the answers to these, because a lot of them don't. First, before we delve into some of these issues, tell me as a physician why you feel like compelled to write a book on behavioral strategies.
Yeah, after having helped to care for thousands of patients, I realized that both the things that I've learned from my families and how they've been successful caring for their loved ones, what strategies worked for them, what strategies didn't, and also what I know because I understand the brain and how it functions, and also how it breaks down and when things don't function correctly in great detail. I realized that there was just a lot of knowledge that my co-author and we had in our heads, and we often will explain it to our families when we're with them in the office. But even in a somewhat leisurely appointment, you can't explain all the things that you would love to be able to say. And then there's all these other people who I know are out there that, aren't able to get in to see us. And we really felt, compelled that we really needed to write this book and get the knowledge out there. Like I said, some of it is passing on knowledge, to help sort of family to family, but some of it is using our knowledge of, the brain, what we know about how it breaks down in different diseases, how it can be helpful.
So let's talk about this in terms of the different stages. I mean, I know people's concerns about behavioral changes, really to me, and maybe I'm not sure this is for everyone, it feels really, it takes the biggest adjustment in the earlier stage when you're first entering this journey. And then when you reach the later stage, I think in the middle stage, we kind of take a little bit of more of a pause, needs change. But to me, the beginning and the end stages have been the most difficult. Do you find that's the case with your patients?
Yes, absolutely. And it's in fact why we actually have written my same co-author and I've written 2 different books. So this book is specifically to help families. It's a guide for them to help their loved ones who are sort of entering that moderate stage of Alzheimer's disease. One way that it's coming is the doctor's appointment sort of switches a little bit from talking, 90% to the patient, 10% to the family, and all of a sudden it becomes the doctor's talking 90% to the family, 10% to the patient. So this book is sort of written for that later stage. But we have this other book, 7 Steps to Managing Your Memory, What's Normal, What's Not, and What to Do About It, which is actually written specifically and directly to the individual who's noticed some memory problems and is trying to figure out, is it normal, is it not, what to do about it, and also how to cope with it. Because I totally agree, it's in these early stages that it's very difficult for the individual to come to terms that they're forgetting things.
Right.
Sometimes it's because it's like, number one, psychologically, it's not pleasant to think about the fact that you're forgetting things, to worry about the fact that you're developing Alzheimer's disease. But in addition, from a neurologic standpoint, people actually have trouble remembering the fact that they forget everything.
Yeah, and we've all seen that happen. What I like when I was reading your book, you talk a lot about attention, and attention it's interesting in the context of memory. I mean, my husband always says, I'm a bit ADD, and he always says, I think you're not paying attention. That's why. So tell us about that connection between attention and memory, and really what we can do to help someone who has a neurodegeneration in terms of like really improving the focus of attention.
Yeah, that's a really great point. So I think, all of us in society today, regardless of what age one is and whether you have ADD or dementia or anything else, we all are very distracted, right? There's things coming into us from all times. These days, half the time you're watching a Zoom presentation, but your email's still on, and you're hearing a bing and you're being distracted by that. Well, we can actually only pay attention to one thing at a time. So when people have paying attention to two things, they're not really paying attention to two things. They're switching back and forth, one thing to the other. And you can only remember what you're paying attention to. I think most of us have had the experience that, you may be talking to a friend at the same time that you're driving. And all of a sudden you end up somewhere and you're like, I don't have any memory of how I drove here. And that's because you weren't paying attention to your driving when it was going on. So you have to pay attention in order to even have the possibility of remembering it, even for normal individuals.
So what are some of the strategies that we can employ to really, I mean, in the beginning stages, when you're talking to someone who has been diagnosed with dementia, what are those early strategies that maybe they can employ? And then, as we mentioned later on, you're talking to the caregiver. What can caregivers do to really help sharpen the focus?
Yeah. So in the earliest stages, what we want to do is to encourage the individual to not dual task. So maybe, they were used to, doing a million different things at once. They're used to, driving while they're talking on the phone and things like that. So you have to encourage your loved one who's only mildly impaired, be like, look, dad or mom or brother or spouse, I want you to be able to keep driving and doing it safely. And you can, if you just, turn off the radio, stop, talking on the telephone, certainly don't look at your phone while you're driving, and just pay attention. And for individuals in the later stage of the disease, it's more just to help them be there, be present, be in the moment, be with you. And often that means turning off distractions. So in the later stages, you as the family member have to take the lead and turn the TV off, go into another room if you're trying to have a quiet conversation away from the kids or the pets, or whatever other distractions are around.
So, it's interesting when you observe a person with dementia, you realize, and you mentioned this in your book too, that longer term memories stay with them. We see that like with music, things like that, but also, even with my mom, she's all of a sudden really vividly remembering her parents, right? And, who have been deceased for a number of years. Why is it? What is happening in the brain that allows us to hold on to longer term memories versus shorter term ones?
So when we form memories, they are formed and initially stored in a small structure deep in the temporal lobe, sort of deep in our temple region, called the hippocampus. And it's the hippocampus that allows us to remember what we did 10 minutes ago, what we did yesterday, and what we did last year. Now, over time, mainly as we're sleeping, the memories also get represented throughout the whole brain. And in Alzheimer's disease, the most common cause of dementia, what happens is the hippocampus and related structures deteriorate. They get attacked by the Alzheimer's proteins. And so the ability to learn new information is lost, the recent memories are lost, and all that's left are the older memories. So your mother is talking more and more about things that happened long ago because those are the memories that are the ones that are present for her. The newer memories may have been lost by the Alzheimer's process.
So is it good to jog long-term memory? Is there any relationship between long-term and short-term?
Well, so for sure, the main relation is things go from the short term to the long term in the healthy individual. I think that it is often pleasant and pleasurable for someone to be able to bring up a memory. And I think that if you can give a little hint, and say, oh, you remember, Mom, that was the show that we went to, 20 years ago when we went into town that night. And if your mother can then say, oh, I remember, yes, that was a wonderful show. We really had a nice time, and I enjoyed spending time with you and your partner and, things like that, then I think it's great. If you find you're providing these prompts and it's just providing frustration and, your mother is not able to pull the memory up, then obviously that's probably not the right thing to do. If your question is, is it going to be sort of helpful at a neurobiological level? I don't think it's critically important. I think the most important thing is to do it if it creates a moment of joy.
So probably a lot of, and I'm sure you hear this in your practice all the time, but some of the behavioral changes like hallucinations or delusions are probably among the hardest things to deal with. Tell us what's happening there inside the brain, and and then what are some of the strategies? It's not helpful to say, no, it's not, that's not happening. So how should we be communicating and helping someone come out of this delusion or hallucination? And I realize they're two different things.
Yes, absolutely. And so let's just talk about them briefly one at a time. So a delusion is when there's sort of a fixed mistaken belief that's a little bit difficult to talk someone out of. And so, a frequent one that I hear is someone is convinced that, let's say their mother came to visit them last night, or, someone else came to visit them. Maybe they did something unpleasant. They said harsh words. I had an argument with my mother last night. I'm all upset about this. And, to try to convince the person that, no, that actually happened 50 years ago, Mom, that didn't happen last night, isn't usually helpful. You're usually not going to win that type of sort of logical argument. And so, we usually recommend that you simply sort of distract the person, get them talking about something else. You say, yeah, that's too bad. Hey, let me tell you what happened to me today. You won't believe what happened. And, launch into a story like that. Or you could sometimes, pull out an old picture book and you say, let's take a look at some pictures of your parents, and let's go through some old photo albums. Things like that can sometimes turn a negative event into a positive event, but you definitely don't want to be arguing with someone. And then the hallucinations is similar. And the main difference in hallucinations is, of course, that it's happening in front of somebody. Somebody might be noticing that a person is sitting in a chair when there's no one sitting in the chair, or there may be people walking around doing different things. Hallucinations are often non-threatening. Most of the time, at least initially, individuals who see hallucinations, normally it's people that have at least some what we call Lewy body pathology in the brain. They'll often see people or animals, And I think the most important thing for family members to know is to not get upset about it. If the individual who's seeing the hallucinations isn't upset about it, don't you get upset about it. And again, the important thing to do is to try to redirect the person, get them sort of talking about things that are actually reality-based. But, if they're, really interacting with the hallucination and it's not bothering them, don't let it bother you. Let them spend a few minutes with the hallucination. I've had patients who enjoy petting animals that aren't actually there, sometimes enjoy that someone has visited them and given them company if they're living alone, even though no one is there. And if the hallucinations are threatening, I recommend using what we call the 4 R's, which is number 1, reassure the patient that everything's okay. Number 2, reconsider. So consider things from the individual's point of view. Number 3 is redirect, like we were talking about, direct them to other activities. And the 4th R is relax. And that's what we all need to do, to take a deep breath and relax. Because if we are upset that our loved one is having a hallucination, or we're anxious, or we're angry, or we're frustrated, we're going to reflect that emotion to the individual, and it's just going to escalate things.
Yeah, and I think it's important to point out too that sometimes hallucinations can be a lot more subtle, right? We've interviewed people on Being Patient who have been misdiagnosed, saying that they had Alzheimer's when they really had Lewy body, because the hallucination was as simple as what they ate tasted. If they ate something salty, it tasted sweet. If they ate something sweet, it tasted salty. So that was a type of hallucination, right?
Yeah,
it wasn't necessarily characters or people.
Mm-hmm.
There's a really great question that's come in from Diana McIntyre, and she is asking, she says, my 89-year-old mother was diagnosed with dementia in January. The neuropsychological testing indicated vascular or Alzheimer's, or possibly both. Vascular makes sense because of the financial scam she's been a victim of, but I don't see typical Alzheimer's symptoms. Yet the neurologist keeps persisting it's Alzheimer's. Yet if we place a vascular patient in an Alzheimer's setting, can't that be upsetting? So I think too, this is also a huge problem, right? Like how much of these behavioral strategies work for different dementias if actually people don't know exactly, and misdiagnosis is extremely common.
Yeah, this is a wonderful point. And the first step of our 6 steps to managing Alzheimer's disease and dementia is to understand dementia and to make sure your loved one has the right diagnosis. So a few general comments. Alzheimer's disease is by far the most likely diagnosis in an 88-year-old. That's number 1. Number 2, almost every 88-year-old, or even people in their 80s or their 70s or their 60s, are going to have some little teeny tiny, almost microscopic mini strokes that are going to be a contributing factor. If the individual has trouble with memory, first and foremost, that is most likely going to be due to a primary Alzheimer's disease diagnosis, and often with secondary vascular disease. So most of the time, if I see an 88-year-old walk into my office, they're going to have Alzheimer's disease, because just statistically, somewhere between 60 to 70% of dementias in that age range, it'll be Alzheimer's, but almost always there's going to be a vascular contribution. Now, the good thing is that I want you to be reassured that once the dementias get to a certain stage, many parts of the brain are impaired. And what we really are doing is working to address function and address symptoms. And it doesn't matter to a huge extent whether the function problems and the behavior problems are due to Alzheimer's or vascular or Lewy body. or some combination thereof. We can use the same approaches, like the 4 Rs I was saying, for all of those. And actually the same medications, medications like donepezil and other cholinesterase inhibitors can be used for all 3 of those conditions. So number one, I do want people to get the right diagnosis, but the good thing is feel reassured, even if they're not, same strategy, same medicines can help.
Let's talk a little bit about the medicines. I was just having this conversation with my family because we have no idea really how the medicines are working, right? I mean, with neurodegeneration, you're witnessing a decline over a longer period of time. So was the decline as rapid? I don't know if she weren't on medications. I was surprised to learn from another professional that Aricept actually is only intended to last for short periods of times, up to 6 months, and people stay on it for years.
That's not quite right.
Okay, clarify it, because I've heard a lot of different things.
Yeah. With all due respect to the other professionals. So the way medicines like donepezil, brand name Aricept, work, and the other ones are rivastigmine, brand name Exelon, and galantamine. All of these medications help to raise up a neurotransmitter called acetylcholine, which drops in all 3 of the diseases we're talking about: Alzheimer's, vascular, and Lewy body. And by raising it up, what the studies clearly show is you can actually turn the clock back on these dementias by 6 to 12 months. So I think that's where the 6 to 12 months comes in. So for 6 to 12 months, the person is actually somewhat better than they were initially. So what I mean is when someone comes into my clinic and I prescribe one of these medications, I can make their memory like it was 6 months ago, or maybe even a full year ago. And the earlier I see them and get them on meds, because there's more living brain cells, the more likely it is I can get the full 12 months turning the clock back. Now, over time, I cannot stop the clock from ticking down. It's still going to tick down. It's even going to tick down at the same rate. But as long as they initially had that turning the clock back, they're always going to be 6 to 12 months better off on the medicine than off it. And one of the terrible ways that I know this is correct is that, if family members don't understand this because their doctor didn't explain it properly, and they stop the medicine, what happens is they often plummet 6 to 12 months worth of memory function in 1 to 2 weeks. So that's really how it works.
How do we know what the right medicines are? I mean, there's not a lot to choose from, first of all, right? And basically the ones on the market are, with the exception of the newly approved controversial Aduhelm, the ones that we most would know about are the ones that really treat the symptoms, right? They're not reversing neurodegeneration. They're not making us better, but they're treating the symptoms. So how does, I know I get your perspective as a doctor and how and why they would be a good thing in turning back, but for people like us who do not have a medical degree, is there anything are there questions we should ask? Is there anything we should know in order to understand if this medication is having any impact at all? I mean, what are some of the indicators there?
Sure. So one thing that is tricky about medications to treat any problem, whether it's to improve memory, to treat trouble with agitation, to treat hallucinations, to treat anger, is that it's unlikely to stop these problems or fix these problems completely. So, but it is likely, if it's working, to make a significant difference. So so how do you know? Well, you really have to sort of do your homework, and you need to write down, so how many times does my loved one get angry? And how long does each episode last? And if you write it down, say before the medication is given, they're getting angry, let's say, every single day, and you add it up all the times, and it seems to average about 35 minutes each day that they're angry, they're yelling, they're screaming, they're pounding, they're aggressive toward me, something like that. And then you try a new medicine, you find out, oh, now they're only angry 4 times a week, and you total the time, and it's only about 17 minutes each day. So it's still happening, but it's a lot better. So that's one very helpful tool, is to try and see, although the problem isn't completely eliminated, is it helped?
Okay, so that's really helpful, and we all probably need to do that more to gain. It's always in hindsight when you look back and say, oh wow, it's so much better, or it's worse, it's better now. I have a question though about the deterioration of memory, and one question that comes up quite frequently is people scratching their heads saying, what stage is this person in and what does this mean, right? Because short-term memory, there's an impact, and then are there clear markers to say this person's at the beginning, middle, and end in terms of memory loss? Like, forget all of the other complicated stuff, but just in terms of memory.
Yeah, so I mean, there's different ways that people approach the staging of dementia, but so what I would begin is even the pre-dementia stage, which would be mild cognitive impairment. So in mild cognitive impairment, there is some people noticing that there's difficulties with thinking and memory. It can be the individual themselves, their family, or their doctor. The individual does indeed have problems when tests of thinking and memory are given, but at the same time, they can still do all their sort of daily activities. Maybe it's a little bit harder for them to pay their bills, make a meal, balance their checkbook, but they can still do those things. So that would be mild cognitive impairment. And then the next stage, let's say very mild dementia, that would mean that just one of their sort of complicated activities of daily living, they can't do by themselves. So maybe if they can't do their finances by themselves. They can still drive, they can still take their medicines, they can go grocery shopping, they can make meals for themselves, they can do the laundry, but they just can't get the bills paid on time, balance their checkbook, things like that. That would be very mild. And once you're into the mild stage, several of those complicated activities of daily living, they're having trouble. So in addition to the finances, they really can't make meals and they can't take their medicines on their own. And then things get into the moderate stage when one of the basic activities of daily living are impaired. They have trouble dressing, eating, toileting, doing hygiene, like bathing, brushing teeth, things like that. So that's a little bit how I think about the different stages. I like to think about them in terms of function.
Right. We have another question saying, what role does excessive sleep play in dementia? So it's not like, go get your 8 hours and it's good for you. It's like, what if the person is excessively sleeping most of the day? What does that mean?
So the first thing to do is you probably want to double check with the primary care doctor that there's not either a medical illness that's causing them to sleep too much, or that they don't have a sleep disorder. The most common sleep disorder would be obstructive sleep apnea, where people are not only snoring loudly, but having pauses and not getting enough oxygen. They're having awakenings. And so they may sleep for 12 hours, but that's because they can't get 8 hours of consolidated sleep. The second most common reason that people sleep excessively is they're bored. The way you know if boredom is the problem is if there's something on the agenda that day, they can be awake and alert, they have no trouble, they can be active and participating. Then you know, oh, the problem is really just that they're bored and they have nothing better to do. They might as well stay in bed, might as well sleep. And the last thing I'll note is that sometimes the sleeping problem is due to medications, whether it's because, let's say at a prior time in their life, they were having trouble sleeping, so they're still taking a sleeping medicine at night, or they think to themselves, well, I used to go to bed at 10 p.m. and wake up at 6 a.m., but now I'm retired. So I don't want to get up at 6 a.m. anymore. I want to get up at 8 a.m. And going to bed at 10 and waking up at 8 sounds normal, but actually it's 10 hours and it's probably too long.
What do you believe is the best way to communicate with someone who has neurodegeneration? I mean, I'm kind of confused about this as well. Is it better to acknowledge there are memory problems, but we're here to help? Or is it better to pretend like there aren't memory problems? Because oftentimes I find, at least in my mom's case, she doesn't think she has any memory problems, but she does. And so is it better just to pretend that there's no memory problems? Like what do you tell your patients? Like
it really depends at least a little bit on the stage and the circumstances. So let's just say that your mother was in the very earliest stages and she's still living at home, but let's say she's having those financial difficulties that we were talking about. Well, it will be important for her to acknowledge that she's having at least some difficulties so she can let you help her with her finances so that she doesn't start bouncing checks or fall victim to financial scams, or have all her electricity shut off or something like that. But after that early stage, for those specific reasons, when somebody's in the moderate stage, it's not helpful to remind them that they have dementia. It often just causes them to become upset. They may be angry and not believe you because they don't remember, like I was saying, that they have trouble remembering, or it may make them sad. They may cry, and you don't want to do that. And then, of course, probably in a few hours they won't remember the whole conversation anyway. So, in general, we recommend going back to those 4 R's as much as you can, and just reassure them, think about things from their perspective, distract them, get them onto something else.
Yeah, it is. And one thing that I think you're really highlighting for us here is as you move into different stages, you have to adapt, right? I mean, there's not like any right answer, but you have to move with the person.
Absolutely. And that's one of many reasons that we wrote the book, because I hear that all the time, almost every single clinic. I hear that from family members, like, I thought I had everything under control, and then this happened. And then I got that under control, and then that happened. And it really is a moving target. And that's why I think families need a resource that, is sort of like, once you know the different topics in the book, let's say, your loved one all of a sudden thinks that you have been replaced by an imposter. It's like, oh my God, like, what is this? How do I deal with this? And if they, read the chapter on vision and the problems that come up with vision, they're like, oh, that's right, there's something in that chapter. I got to go read that chapter again.
Yeah. What's the most common thing that comes up with your families? I mean, it might be hard, but like off the top of your head, enlighten us. What comes up the most?
I think the top problems are probably trouble sleeping and incontinence. Those are 2 of the biggest problems. And, we've talked about sleep a little bit. I will say that although your one commentator mentioned the trouble of sleeping too much, usually it's the opposite problem. I get a lot of
Not enough
families
sleep
coming in and saying, my loved one's up at 4 a.m. You got to do something, doc. And usually the problem getting up at 4 a.m. is the individual is going to bed at 8 p.m. at night.
right?
So add the hours together. If they go to bed at 8 p.m., by 4 a.m., that's 8 hours of sleep. And so that's actually enough sleep for them.
where are you on taking sleeping pills? Because that also comes up a lot, and I've heard I've heard doctors say it's better than no sleep, and I've heard other doctors who say absolutely not, stay away.
Yeah, so there is actually good data on this, that the sleep that's primarily induced by sleeping pills is not really healthy sleep. And so I try to use non-pharmacologic means whenever possible, with the exception of two pills, and those are melatonin, which can help to just get the sleep cycle into the right rhythm. So melatonin, as you probably know, is not really a sleeping pill. It won't sedate you, but it can align your rhythm. So let's say this individual who's going to bed at 8 p.m. and waking up at 4 a.m., you really want them to go to bed at 10 p.m. and have them get up at 6 a.m. Well, giving them melatonin, at 9 p.m., even if that means you have to wake them up, can help to reset their rhythm. And the same thing if somebody's going to bed, at 2 a.m. and keeping everyone up till 2 a.m., giving them the melatonin at 9 p.m. can help get them on a good cycle. The other medicine is actually acetaminophen, plain old Tylenol, and not Tylenol PM, just plain old Tylenol, because all of us as we get older have little aches and pains that we may not notice during the day, but can keep us up at night. And having something like that can help to quiet down those aches and pains.
We're also getting a question about Belsomra, which is the FDA-approved insomnia drug for Alzheimer's. Do you know about this one?
Yes. So I believe the study showed that it can help individuals fall asleep 22 minutes earlier. I think that's what the study showed. I do not recommend it. I don't recommend any of the sleeping pills like that. Now, again, the data that I'm familiar with shows that it's not really good, high quality, restful sleep. It is habit forming. If one looks in the literature, there's actually a lot about this. It's just not, I'm not in favor of it. But having said that strong statement, look, there are exceptions. There are individuals who have hit a certain stage of dementia, and their normal sleep pattern is completely fragmented. And yes, some of these people do need a dose of that, or a dose of Ambien, or a dose of trazodone, or something like that. But I guess what I would say is it's not my first, second, third, or fourth, or fifth thing that I reach for. It's the sixth.
Okay, and I want to talk to you just a little bit about, we know that sleep is good for our brain health, but how much does sleep have to do with our memory? So, and I'm not talking about longer term memories, I'm talking about impacting remembering things on a more short-term basis. How important is sleep?
Yeah, so there's sort of three reasons that sleep is important for memory. So and we sort of touched on each of them a tiny bit. So if we don't get good sleep the prior night, we all know that we're tired. And when one is tired, you're not able to pay full attention. And as we talked about, you need to pay attention in order to learn new information and get it into the hippocampus. The second reason that sleep is important is that it is mainly when we sleep that these short-term memories of things that happened, that day or the week before can get permanently into our long-term memory store. So we need to get good sleep in order for that transfer to take place. And just an aside on that, so if students are cramming for tests, the reason that they may remember it for the next, day or two, if they're taking the test the next day, but then they don't remember it next semester, is because they have not given themselves enough chance to sleep after they learned each part, of what they should have been learning across the whole semester. And that's why it disappears. So we need to sort of learn things, sleep, learn things, sleep, learn things, sleep. And the third reason that sleep is important for memory is we all make a little bit of this Alzheimer's protein called amyloid during the day. but our brain has a wonderful mechanism of flushing it out while we are sleeping. And so if we don't get enough sleep, it's going to cause this amyloid to accumulate and make it more likely that one will develop Alzheimer's disease in the future.
Right. All right. Well, Dr. Andrew Budson, tell us when the book is coming out.
September 20th.
And how do people, I guess it's on Amazon, right? They can.
It's on Amazon. And the other thing, I'd love to support local bookstores as well. So let your local bookstore know that you'd like a copy, and I'm sure they'll reserve one for you.
Okay, and just to let everyone know, the book is called 6 Steps to Managing Alzheimer's Disease and Dementia. Nicholas, my producer, can put a link to the book. Dr. Andrew Budson covers a lot of the behavioral strategies we should all been employing. And, you know, it's really great to have a doctor who is focusing on cognitive and behavioral neurology. I think that means a lot and carries a lot of weight. So thank you for your work. Thank you for your time. You know, I'm sure we'll get follow-up questions, but we'll send them your way on being patient. And yeah, I mean, how do people, do you have a blog or anything, or how do you?
Yes, I have several blogs. I have one on Psychology Today and another on Harvard Health. If you Google those terms with my last name, Budson, it'll come up. I also have a website, andrewbudsonmd.com, and on there is a link to my email address, and I'm always happy for people to email me with questions as well.
Great. Thank you so much for that. Access is extraordinary. We really appreciate your time and dedication. And for any of you who've missed part of our interview with Dr. Budson, we always repost these on beingpatient.com or on our YouTube channel. So make sure you subscribe, but more importantly, sign up for our newsletter, because that's when we tell you what the upcoming talks are. If you go to beingpatient.com, you'll see a pop-up or a form where you can sign up for our newsletter. Dr. Budson, thank you so much for joining us, and we look forward to talking to you next time.
Great. Thank you for having me.